on to debate number 2 with Craig Cole and Elizabeth Franklin. And the idea for this one is to sort of bring some of our earlier discussion back into a context of how do we address these questions, what's the most effective and most caring way to sort of address these issues with patients. Craig, how would you react to the initial discussion here and put it in the context of how you deal with your patients?
Yeah, thanks, Ron. And, you know, when I go into a room to talk to a patient that, you know, has a disease that has a potential of curative intent, you just don't, you know, walk into a room with a journal and say, you know, read this, it's curable. You really do have to take a bigger perspective of and just like Sanjay and Jonathan said, you know, what biology does the person in front of me have? You know, is the biology they may have in tumor X, but is the biology and the performance and the presentation really fit what the papers say? And then what is their access? What is their access to care? If they're unable to get to the clinic, you know, for their treatments, is their disease curable? You know, I unfortunately have seen patients who have succumbed to their disease not because of biology, but because of access to care. And were they able to receive their treatment, or were there other comorbidities that stood in the way? And those comorbidities can be personal within the patient. They can be other issues outside of that. If they have to not buy groceries because the medications that they have are expensive. You know, have you really cured somebody when they can't afford their medication? And then I think kind of the most important thing is the goals of what a patient and the provider want. And when I see my patients, you know, I'm sure to sit down with them with a piece of paper. And I use paper to write down things for my patients. We write down the goals of what we actually want to achieve. Because just like Sabine said in the montage, you know, some patients, you know, look at cure as gone for now. And other patients look at cure as the complete elimination of disease and I never want to come back. And so sitting down and talking to the patient and especially listening to the goals of what is their goal of therapy, and then do the best to try and meet that in the partnership. And the culture that the patient comes in with. I mean, all of us are in some way bicultural, that we have the culture that we grew up with and that our families kind of interacted with, and the culture that we live in. And many people have to dodge and weave and negotiate between two cultures. And sometimes the definition of cure in one culture may come in conflict with the definition of cure in another culture. And so, you know, taking a social history and understanding and asking that, you know, what is your goal? You know, what is your goal? What's your family's goal of your therapy? You know, all come in to be very important in having that conversation.
Elizabeth, I'm sure you've experienced many of those issues in dealing with your constituents and colleagues. What do you want to add to the conversation?
Absolutely. It's interesting being in a debate with Craig Cole because I love every word that comes out of his mouth. And I was going to say with Jonathan and Sanjay as well, if and when I'm dealing with cancer in my personal life, this is the team of doctors that I want at my bedside, right? Because walking into a door with someone impacted by cancer, whether it's the patient or the loved one, they walk into that room as a person first, right? They're not a patient first, they're a person with a full life, with values and needs and preferences that they care about. And so we often talk about patients as cure at all costs and care at all costs, right? And so you may have that patient who says, doc, give me the most aggressive treatment. I don't care how I feel. I want to get back to my life. You also may have a patient who says, quality of life is the most important thing to me. When I was in a hospital as a social worker, I worked with patients who absolutely would not lose their hair. Under any circumstance, I will not lose my hair. I'm not doing the therapy if that's what it means. And so that may seem silly to some, but it's extraordinarily important to others. And I think for Dr. Cole, culture plays a huge role in that. So you have to really walk in the door, understand what patients care, understand what their cultural background is about. And we've often used the word hope. I saw that word in the montage as well. And you have to understand what patients hope for. And it's incredibly important. Sanjay kept talking about sort of the change over time. Patient hopes change over time. On day one of a cancer diagnosis, most people are afraid of losing their life. 6 months later, they might really care about quality of life and not want to live in pain or have nausea. And then when they're facing the end of life, their hope may be for a good death and that they're able to say goodbye to their loved ones. So it's important to follow patients throughout their trajectory to understand what they really care about. Again, not as a patient, but as a person first and foremost.
How do you address patients who don't really want to hear the word cure used? Or, I mean, how does it work? Maybe Dr. Cole, in your case, or with patients, or, do you find that come up in conversation? It was actually mentioned on a couple of the patient comments in the montage. How do you respond to that?
Yeah, absolutely. That there are definitely patients who when we say that this treatment is with curative intent, and they're like, well, what does curative intent mean? And it means that we're willing to, are you willing to accept a certain level of risk and discomfort for now for possible benefits in the future? And that's kind of the trick about a lot of this. Cure is something that lies in the future, and that is very difficult, I think, for patients. And so I'm very, cognizant and very careful with that when I'm one-on-one with the patient. That, if you're saying that something is curative, that you really have to be prepared to deliver on that. And also, just like Elizabeth said, is being able to react in real time, to not say that we're going to do this therapy to the very end and be not aware of the circumstances surrounding a lot of that therapy, because things change all the time. And patients change and our goals change. And so reassessing that in real time with every step. The patient I just saw before I came in, we're treating him with curative intent, but I made sure that before we started the next cycle of therapy, that our goals were in line, that the side effect profile was in line with his eventual goal of cure.
And Elizabeth, what did you find the most important or the most telling sort of way patients react to this word?
Yeah, it's interesting because every patient is different. We've talked about that throughout both debates. And you have those patients. I've talked to people who say, give me the data, right? What are the chances I'm going to be alive 5 years from now? I want to know the stats. Show me the New England Journal of Medicine article. I'm all in the science. You have patients who say, I don't want to hear a single percentage, right? Don't give me the data. Don't give me the stats. I'm unique and I want to be treated as such. And that's why it's so incredibly important for physicians to understand that when they walk through the door. And as I'm hearing each of our physician colleagues speak on this panel today, I also realized that, they're such an important source of hope. Patients look to the physician to give them answers. And it depends on how the patient wants to receive that information and how much information. But physicians really serve as a source of control for the patient in an otherwise uncontrollable position, right? And so it's so incredibly important, the words that come out of physicians' mouths, the words that come out of nurses' mouths and social workers' mouths, because they're truly words that harm irreparably. Words like, there's nothing more that can be done, right? You can't bounce back from that. Yeah. Versus, we're going to do everything we possibly can. And I want to know exactly what you want to get out of treatment so that I can be your partner on this journey. So it's really understanding the individual patient and what they're hoping to get out of it.
Well, great. Well, I'd like to thank all four of you for a great conversation, and we'll prepare shortly to go into our bigger panel.